Just so we can be acquainted with Dr. Martin, just come on, sir. I just wanted to introduce him as Associate Professor of Surgery in the Division of Pediatric Surgery. He is the Surgical Director at UAB/Children's of Alabama Center for Advanced Intestinal Rehabilitation. A native of Delaware, Dr. Martin is a specialist in intestinal rehabilitation, surgery, and a scientist. His research interests include mucosal immunology and B-cell mediated antibody development. Thank you, Dr. Martin. Sure.
It's truly a pleasure to speak in front of you. The last time I was at a pulpit on a Sabbath, I was in probably high school speaking for Youth Day. So although this is a health emphasis day, I don't take lightly the opportunity to speak to you on Sabbath. And thank you to the organizers and the pastor for allowing me this privilege. So I'm at Children's Hospital of Alabama, and it's interesting that I come to church here on most Sabbaths and sort of come in and go out, and I don't really know a lot of the members, and so a lot of the speakers here today, I'm really learning a lot, and so I want to take a few slides, just introduce myself and my specialty, not so much to showcase, but just to offer sort of my expertise so that if I can help in any way in the future with your kids or even with yourselves, I'm happy to. So Children's Hospital of Alabama, so when you drive down 65 heading north, the bright shiny building is the new Children's Hospital, and it was built in 2012. And it's a really large children's hospital, so it's the third largest children's hospital in the country and the 10th busiest in the country. So a little bit about myself. The talk is about intestinal health and colorectal cancer, but some of the conditions I treat, a few pictures here. The next slide shows a condition that I treat. It's called tracheoesophageal fistula. So what this is where the dot is on a baby's esophagus, so the esophagus should be connected down to the lower part of the intestine. So in this condition, this is a blind ending connection, and this is the trachea or the windpipe. So the lower esophagus is connected to the trachea. And just a view of one of our operations, and so you can see the esophagus. This is looking inside a baby's chest. So this is the esophagus that's not connected, and this is the lower part of the esophagus going to the trachea. And so the operation we're able to do is connect the two ends of the esophagus and separate it from the trachea. So to get into a little bit more about our talk today, so preparing for it, colon cancer, intestinal health, did a little bit of research. And so from 2 Kings 8:16, in the 5th year of King Jehoram, son of Ahab of Israel, Jehoram, son of King of Jehoshaphat of Judah, began to reign. So King Jehoram is one of the kings of Israel. And the research says that the Lord smote him in his bowels, or his intestines, with an incurable disease in the process of time. After the end of 2 years, his bowels fell out by reason of sickness, so he died of sore diseases, indicating that the king suffered from some kind of disease which affected his bowels. Among the various diseases which may be associated are prolapse of the intestine or colorectal cancer. And viewed by the modern physician, this may be one of the early cases of colorectal cancer in the Bible. So how does cancer form? And some of the topics that we'll discuss today are, between the different speakers, are going to be some recurring themes. So what it starts off with is a little bit of, you can see, we'll just sort of go from screen left to right. It starts with a little bit of proliferation, and what causes proliferation can be inflammation, and that proliferation gets larger, and you have a polyp that's formed. And so the polyp is this structure right here. And so once you have a polyp, you can have some of the cells within the polyp. They can proliferate or regenerate pretty fast, and when that proliferative process gets out of control, those cells become cancerous. And so what you have is called an adenocarcinoma. which is a cancerous polyp, and then you have cancer. And what distinguishes a benign from malignant cancer is when these cells get out of the context or get out of the borders of the polyp and spread throughout the body. So here are some colonoscopy pictures of polyps. So just a quick poll. Who here has had a colonoscopy before? Very nice. And who here is above the age of 50? You don't have to raise your hands, but so you know, one theme of this talk will be the importance of colorectal cancer screening. So symptoms of colon cancer. It's often asymptomatic, and so the worrisome thing is that many of us, or some of us, could have early colorectal cancer but not have any symptoms. Another symptom is abdominal pain, and in kids, adults, a lot of things can cause abdominal pain. Stress, poor diet, constipation, but one of those symptoms could be from a colorectal cancer. Change in bowel habits. So what that means is if you're a regular stooler, meaning that you have 2 to 3 bowel movements daily or one daily, and it's usually not hard, you're not constipated, if there's a change in those stooling habits, that could be an indication that there could be a problem. So often, if you have a large rectal cancer growing, the caliber of your stool may change. And so if you usually have a large caliber stool, if it goes down to being pencil thin in caliber, that could be concerning as well. Rectal bleeding or black stools. Sometimes if you give your kids certain foods, they might come and say, my stool is red, and it could be from that food. But if it's recurrent, or you have bleeding in your stools, and if you have bleeding in your stools from the top part of your intestine, by the time your body sort of digests that blood, the blood becomes black. So you might see blood in your stool or in a toilet bowl, or you might see really black, tarry stools, and that's an indication that there could be a bleed going on. Weight loss, fatigue, urge to move your bowels when there's none needed. So if you have the urgency to go and you go to the bathroom and sit down, nothing comes out, that could be a problem, a sign that it could be a problem. Also an abdominal mass. And so if you realize that your clothes are fitting differently, your suit jacket's not buttoning well, your belt is tight, there could be a mass which could be secondary to a cancer. And obstruction. And finally, hemorrhoids. So hemorrhoids, I think we all know what they are. For those of you who don't know what they are, basically hemorrhoidal tissue. We all have hemorrhoids, believe it or not. But symptomatic hemorrhoids are when the tissue around our anus becomes engorged, usually because of straining, and that engorgement of the tissue can cause bleeding. So if the straining is caused by a colorectal cancer, then that could be an indication that there's a problem other than just hemorrhoids. So screening. So screening is really used to prevent cancer, and it's important for early detection. So it's one of the few cancers, by adhering to screening protocols, that you can certainly reduce your risk of developing cancer. And if you do have an early cancer, often if it's caught early, it can be treated. So 5 key points. So certainly screening reduces mortality. All persons over the age of 50 should begin regular screening. And so how colon cancer is screened, it's a little bit controversial, but certainly when you approach the age of 50, you should be in close contact with your primary care physician to be sure that he or she, your primary care physician, is instructing you properly on how to screen for colon cancer. High-risk individuals may need to be screened earlier. So high risk means if you have a family history of colon cancer, and usually it's a close family history. So if your mother, your father, or a close relative developed colon cancer, it's an indication to be screened early. And just to sort of hit home the point that colon cancer can be prevented. So in the United States, it's the second leading cause of death, cancer death in the United States, behind breast cancer. Also, there are 140,000 new cases each year and 56,000 deaths. And the deaths really come from these cancers being detected at advanced stages. And so, again, the importance of paying attention to your body, doing preventative measures, which we'll talk about here shortly, and early screening. Affects women and men equally and affects all races. So deaths by state, so looking at Alabama, we have 15.1 to 16.4% risk of death. So these are patients who develop early stages of colorectal cancer. That's our risk of death. And so there are some states that are doing worse than ours, but certainly we can do much better. Also, screening rates. And so the screening rates in Alabama are also right around just below 70%. So certainly there could be better screening rates in Alabama. And looking at our screening rates again, and so there's been an increase in screening because of just a real push from the medical specialties and primary care physicians to improve and increase screening rates. And 1 in 3 adults between the ages of 50 and 75 are still not getting screened as recommended. It sounds like from the hands that we're doing much better. And if we are doing better, it's an opportunity to sort of share our knowledge with our neighbors and friends. But certainly, I'm sure there's some of us in here who have not been screened appropriately. I think we saw this slide once already. And so we're all familiar with this, and from our last talk about New Start. And this is something that when I was in Adventist school as an elementary student, we did the project on New Start: nutrition, exercise, water, sunlight, temperance, air, rest, trust in God, trust in divine power. And so all these things, if you think about it, they can address, I think, almost any condition that we may have or maybe risk of developing. And certainly colon cancer is not different. So prevention of colon cancer, you can see a lot of these same things are almost taken directly from our own health message. And this slide I got from one of our adult colorectal cancer surgeons at UAB. And so this is what he tells his patients on what to do to prevent colon cancer. So that when the question comes in, my uncle or father died from colon cancer, how can I prevent it? This is what he's telling his patients, similar to our health message. So eat fruits, vegetables, fiber, limit red meat consumption, a balanced nutritional diet, regular exercise, avoid smoking, aspirin, and screening. So the screening test, there are several screening tests. There are stool-based tests where you can send a sample of your stool to a facility where they check for blood in your stool, or there are new DNA screens where they can look for certain genetic metabolites within the stool that can show if you have potentially risk for colon cancer based on your stool. Also, there are radiographic screens, so getting a virtual colonoscopy or CT scan. The technology is so advanced, so much so that just by taking a CT scan, you can see evidences of early polyps that might be an indication for early cancer. And finally, colonoscopy, sort of the gold standard for screening. And so getting a colonoscopy at the age of 50 is where it's recommended. And what a colonoscopy is, this is a picture of sort of the virtual colonoscopy, but what a colonoscopy is where you're sedated and either a surgeon or a gastroenterologist inserts this camera through the rectum, and with the camera, he or she's able to visualize the entire colon and also look for suspicious polyps that can be biopsied at the time. So we'll just kind of go through a little bit faster to leave time for questions. So the risk assessment. So we're all very different. There's certain things about us that are very similar, but we're all very different, even with the same generalized diet, the same generalized lifestyle. There are different things that give us a higher or lower risk of cancer. And so someone with an average risk is someone who's greater than 50, who has no family history, and no inflammatory conditions of the intestine. Someone who has increased risk or higher risk may have a family history, may have other inflammatory conditions of the intestine, which puts he or she at a higher risk for colon cancer. So again, the 5 key points in this slide has been seen before, but I'll go through it one more time, is that screening reduces mortality. So if you're able to be screened, although you may have cancer, your cancer is picked up at an earlier stage, and so the chances of dying from your cancer are much, much lower with appropriate screening. And skipping down to the number 5 point, being screened is the most important way, most important. And so it's not so much important about what test you choose, but it's more important about just being screened. Hey, Clark. I'll talk slow just so my kids can see me up here speaking. We're almost done now. So sort of shifting a little bit from colon cancer to intestinal health, and we just have 2 or 3 more slides left. And so a lot of my research deals with the intestinal microbiota. So what that means is if we were to take my stool sample and your stool sample and look at the bacteria in the stool, that bacteria can tell us a whole lot. It can tell us about our diet, tells us about our genetic risk. And so the intestinal microbiota is also one of the biggest immune systems or biggest immune centers in our body. And so a lot of the bacteria in our intestine are good, and certain things can make some of that good bacteria shift to a more harmful, negative bacteria. And so just to look at this slide, looking at the GI tract, if you were to take 2 large tennis courts, the surface area from 2 large tennis courts, that sort of equals the surface area of our GI tract. And so the entire GI tract is lined with bacteria, and a lot of the bacteria is good. In preparing for this talk, it was very interesting. I got this reference from PubMed. PubMed is an online reference that I look for research articles of all types. And so this is a published peer-reviewed article. What peer-reviewed means is that the researchers submitted their research and it was reviewed for validity and rigor and scientific rigor. So this is an article looking at the fecal microbial flora of Seventh-day Adventist populations compared to control subjects. So they took, I think, 45 Adventist participants and looked at their stool. And what they found was that compared to the control population, there were low levels of lactobacillus. Lactobacillus counts were very high in Adventists compared to other control groups. And so what lactobacillus is when you take probiotics, that's sort of one of the most common probiotic that you can purchase over the counter. So what this suggests is that by, at least in this research group, and they tried to get a very homogeneous Adventist stool sample cohort. So what that means is, most of us here are Seventh-day Adventists, and we may have similar dietary patterns, but we're all very different. And so at least in this cohort, the microbiota had a higher level of good bacteria compared to a control group. And so what that means is this good bacteria, which is secondary in this cohort from diet, is protective from certain diseases. And this is great to follow the first talk, and some of my research has to do with the gut-brain axis. So what that means is your brain can control your gut, and your gut can sort of influence your brain. And so within our intestine, there's several metabolites that are broken down. Several factors and dietary foods that we eat are broken down by several enzymes in the bacteria. And these broken down enzymes are neurotransmitters for the brain. So you can imagine that if your gut flora is off, those healthy neurotransmitters are going to be out of balance, and it can affect several neurologic functions. And I want to finish with this picture and this phone number. This is a phone number for a general number at UAB, the Colorectal Center. So if you have more questions, particularly, something that you want to talk more about, or even see someone about being screened, the phone number to call, or talk to your primary care physician. And this is a picture of a baby that I took care of recently, just to sort of show the size of some of the kids that we're able to help in our practice. Thank you very much. Yes.
How does aspirin help with that?
Yeah. So there's a pathway that's been linked to colon cancer, and not to go into a lot of the details, but it has to do with a COX-2 anti-inflammatory pathway. And so aspirin is one of the medications to take that can sort of downregulate or decrease that inflammatory pathway. Okay. Yeah, and that question was, how does aspirin help? Yeah, yes.
I know that you're supposed to have a colonoscopy every 2 years.
Yes.
But then when they say come back in 3 years, does that mean that you're a high candidate for cancer?
The question was, you're supposed to have a colonoscopy every 10 years, but if you're asked to come back sooner, for example, every 3 years, does that mean you're a high risk? Sort of depends what the gastroenterologist or the surgeons found on that first colonoscopy. I suspect if we're asked to come back in 3 years, there may have been something that they want to look at a shorter interval. There may have been a polyp that was biopsied that came back benign, but they want to surveil the colon at a shorter interval. Yeah.
Home tests like Cologuard, can those substitute, or should those substitute from seeing the doctor in person or getting the colonoscopy?
Yeah, so the question was, at-home tests like Cologuard, can that substitute from seeing a doctor or getting a colonoscopy? So I think Cologuard, some screening is better than no screening. It's important that if that test is done, and that test has been validated, it's been sort of in the research and development process for 15, 20 years before it came to market. So it's a very valid, sensitive test. But I think once that information comes back, whatever the results are, it's very important to discuss those findings with your doctor. If it comes back negative, I think it's worth the discussion. And also, if it comes back positive, it's worth the discussion. Yes.
My question is, how does the consumption of food, its frequency, its time management, affects the GI tract and thus may affect the development of diseases such as the polyps?
The question was, how does the consumption of food, frequency, consistency affect the GI tract and development of polyps? It's a very, very good question, hard to answer. Certainly, if one eats a balanced diet in moderation and stays away from cancer-causing ingredients in the diet, so carcinogens in the diet, that's going to be the best way for a healthy GI system. Eating 3 balanced meals, having an appropriate interval between meals, and not snacking is very important. When we're not eating, the intestine has an opportunity to rest, and when the intestine is resting, the cells are regenerating, and they're maintaining that important barrier. And so what that barrier is that when we eat foods, there are several levels of the intestine that keep the bad things sort of inside the lumen and allow the good things to come through. So when that barrier could be disrupted because of poor dietary habits, it allows potentially harmful things in the lumen or inside the intestines sort of come through. And when they come through, it leads to inflammation. And that's sort of the early cascade that can lead to colorectal cancer. So I think everything in moderation and staying away from known carcinogens. Yes? Yeah. Question was, does that suggest that we need to take breaks for a while, and how often should we do it? There's a lot of literature and a lot of opinions on fasting. Some people fast. Maybe a lot of us might fast in here for spiritual reasons. Some people fast to decrease calories. Some people fast to lose weight. And so I'm not an expert in all of the diets and the fasting techniques. Just for example, I was speaking with my brother last night. He said he's on a 5-2 fast where he fasts 2 days out of the week, and the other 2 days he eats. And there's so much literature on that. I would suggest that the first thing would be to speak with an expert who's monitored patients who've fasted, not just in this short interim, but longitudinally for a long period of time, to be sure there are no unwarranted side effects from fasting. But I think a general principle, 3 balanced meals, and your last meal being not 10 p.m., not 9 p.m., but dinner time, and allowing the intestines and the GI system to recover. Yeah. Question about probiotics and prebiotics, is that right? Okay. So prebiotics are fuel for the bacteria in the intestine. So prebiotics are primarily starches that, when taking in appropriate doses, are fuel for the good bacteria to thrive and develop. Probiotics are high concentrations of bacteria that are meant to replenish not only the GI system, but can also replenish other epithelial line systems within the body. So they can replenish the respiratory system, the reproductive system, the genitourinary system. And so with probiotics, the important thing to do is to get a reliable source of probiotics. There are different concentrations, different formulations, and a lot of different industry pushed advertisements to sort of make money. And so I think with probiotics, there's definitely a need for it. And it's really important to understand that taking it in a short period of time, you may not see the result, but staying with one probiotic at a regular interval and paying close attention to some of the things that may be bothering you over a long period of time, 4 to 6 weeks, to see if those probiotics make a difference. One more question? Yep.
Let me go back to consumption. I said in the Adventist, we're going to pursue a plant-based diet, a so-called Daniel diet. It's not really most of us. So we do fish and chicken and pork and lamb, pork chops and everything in between. Now, I'm told that by the time the average American child is age 16, he has a certain amount of undigested red meat in his colon. Have you seen any?
No, that's the comment on the first part of your question. Hard to answer. Very controversial within this room about a plant-based diet. Personally, I have not seen what you're referring to, but thank you. That's a discussion for we should have over Sabbath dinner. It's I don't want to go down that path right now. It's controversial within my own house about a plant-based diet. But I have not seen undigested metabolites and materials in teenagers. Thank you very much.
Thank you so much, Dr. Martin, for your presentation.